Hello.
All right, we're live.
All right, we're live. Hey,
Hello.
Zen.
Hey, Brad.
Good to see you.
Good to see you, my friend.
I appreciate you doing this today. Welcome to DocTalk Live. I'm with Zen Hrynkiw, and Dr. Hrynkiw is a neurosurgeon and also an excellent friend of mine. We've been friends for over 20 years. And we're going to talk today about neurosurgery. I think you loaded up some cases. Can you show those cases or the images? Zen, just say hi first.
Hi, I'm Zen Hrynkiw. I'm a neurosurgeon here in Birmingham, Alabama. A good friend with Brad's for over 25 years. Is today a special day for you?
It is. It's my daughter's birthday today. Happy birthday, Annalisa. I hope you're watching.
Happy birthday, Annalisa. Well, I guess we're here to talk about neurosurgery.
Okay.
And I guess the first thing people will ask is, what is neurosurgery?
Fair enough. What is neurosurgery, or how would you define your specialty?
What a neurosurgeon does is treat patients who have diseases of the following: either the brain, the spinal cord, the nerves coming from the spinal cord, or the spinal column and skull supporting the brain and the neural structures.
How would you separate a neurosurgeon from a neurologist?
A neurologist is really better at diagnosing and treating non-surgical pathology. For example, dementia, Parkinson's disease, tremors, that's migraines. These are not surgical illnesses, but they need to be treated. Headaches, migraines, that's what a neurologist does.
Stroke?
Stroke is a little bit in between. We both treat patients with stroke.
Okay. You've pulled some cases, and I appreciate that, some images. Can we start with the middle image?
Okay.
Because that's the brain. And then on the left is a neck, and on the right is a low back. So maybe we could start at the brain and work our way down. Is that fair?
Whatever you want to do,
All right,
Brad.
let's start at the brain.
This is
Hunter, do you have a good image of the brain? If you need to move in, you can.
This is a patient of mine. We've taken all the names out, so this is all fair. Where if you look at this, this is called a coronal image. This is the brain. This is the top. This is the bottom, right and left. And over here you see this ring-enhancing lesion. And here it is if we're looking at what we call axials. So this is an abnormal brain scan. The patient was having symptoms of left-sided weakness and twitching and seizures. They did a scan and found this.
And this lesion is on the right side of the brain.
This
is that
the
correct?
right side of the brain.
And this is affecting the left side of the body.
The brain is kind of crisscrossed. The right brain affects the left side, the left brain affects the right side. That is correct.
So there's this, you see this lesion on imaging. They presented with left-sided, what did you say?
Weakness and twitching.
Twitching, okay. And so you get this scan, and this scan shows this lesion. And so then now what's the thought process now as to what this might be?
Well, an MRI or a CAT scan are pictures. If we took a picture of you, we'd say you have a shirt on. We don't know what it's made out of, however. We don't know when you put it on or when you're taking it off. So this picture shows an abnormality there, but it has certain characteristics that are consistent with either a pus packet or a tumor. So that's the differential.
So this could be a source of infection.
This can be an infection in the brain. We would call that a brain abscess. Or it could be possibly a tumor.
Okay. And so I assume you have to go in there and take out some of it or get some tissue to evaluate it.
Yes. Or you can do a systemic workup looking if it's someplace else which is more readily accessible instead of going into the skull bone.
So if it's a tumor, it might have come from somewhere else.
From like the lung or the breast, for example.
Gotcha. And so what happened in this situation?
In this situation, it's kind of an interesting case. He's a young man, I would say in his late 30s, which is very young. And we found this to be a pus pocket. And we found out that he had a valve that had vegetations on it.
So it came from the heart.
Came from the heart. So we treated his heart with antibiotics. He had a valve replacement. and we were able to treat this without surgery.
So was this is it called rheumatic fever? Is it a valve? So now you're really making me reach back into medical school training now.
His was not rheumatic fever, but that was a very, very common source of emboli and valvular disease, mitral valve. But this was actually aortic, and he needed a valve replacement. And this was actually successfully treated without any brain surgery with high dose of IV antibiotics, and we've done a follow-up, and his scan is now totally clear.
That's excellent. Okay, that's interesting. So
That's
here the patient presents with a neurosurgical problem, and it turns out it's a heart problem.
It turns out to be a heart problem.
Okay. Any questions in there, by the way? Nope. Okay, so we're good.
And we'll probably see about 4 or 5 of these a year.
Okay.
When they really don't need a neurosurgeon, but they come because of brain symptoms.
Should we move now to the neck?
Well, I think we'll kind of jump around, but as a neurosurgeon, we probably see more spine than we do brains in Alabama, because we don't have any brains in Alabama. So we do a lot of back and neck work. Now, what we see is either congenital, we'll see that with birth. We'll see degenerative, which is the most common as we age, our discs wear out. And then we see traumatic lesion. On this scan over here, there's a subtle abnormality. This is just a CAT scan of a person's neck. This man was involved in a motor vehicle accident. He was hit from behind and presented outlying facility with severe neck pain. He was neurologically intact, had some left arm and shoulder pain, but nothing was really done for him. He went to his local doctor, went to a doc in the box, was given medications, narcotics, but continued to have pain. Then he came to see me with this scan. And what he did have is a subtle fracture of his facet joint.
Yeah, I'm starting to see that now. Off on the left side.
On the left, and it's not acute. And
this is 3-4.
It's at 4-5.
4-5.
If you look at this
3-4.
alignment,
Okay.
this lines up pretty darn good, but over here there's a subtle slip.
Yeah.
And then this lines up good.
Yeah.
With a subtle slip like this, we'd call it, it's a unilateral perched facet on that side. And here is the actual subtle fracture that really started healing already, because we did not see him until about 6 weeks out. Because of his severe pain, and he failed blocks, which we sent him for first, failed therapy, failed medication, we decided to operate on this young man. And we did remove this disc, realigned his spine, put a bone.
Do you have any images of that
Post-operative?
that are easy to get to quickly?
Not quickly, easy.
Okay, all right.
And he's done very well after surgery. So we see traumatic events to the spine.
Okay.
Going on, probably the most common thing we see is back pain or neck pain, not related to trauma, but from the wear and tear of daily living. Here is a common thing that we'll see. This is a young lady who has severe back pain and left leg pain. And this is an MRI scan looking at the side. Here's a normal vertebral body. Here's a normal, nice, healthy disc. Normal vertebral body, nice disc. It's losing some water content. Over here you see a vertebral body, L4, L5, and over here you see this little protrusion. So part of this disc material, like a tube of toothpaste, is squeezed out and it's kind of going inferiorly. And then if this is a loaf of bread and we slice it and we look at this image, you see a little piece of this disc material which is behind the vertebral body, and it's affecting the left-sided nerve roots at this area. So this is a small disc protrusion. We also call this herniation or extrusion. Ruptured disc, these are all synonyms. And this is the kind of patient that will have severe pain. Now, how do we treat these patients? Well, we always try conserved modalities first, unless they have a neurological deficit like a foot drop or loss of control of bowel or bladder. I think everyone deserves conservative modalities, and in fact, we sent this lady to either you or one of your partners for some epidural steroid injections, and knock on wood, so far she's doing very well.
Super. Glad
So
to
far.
hear that. The day's not over.
The day's not over. Most patients with a ruptured disc can get by without surgery.
Zen, there was a question that Hunter shared with me going back to the case on the neck.
Okay.
So, can you read the question, Hunter, or is it gone?
Can you ask about degenerative disc disease and nerve block or realignment of C5, 6, 6, 7?
All right. Let me just make some comments, Lee. So this case is involving 4-5 facet on the left, correct?
Yes.
And this was from a trauma.
This is not degenerative. This is actually a car accident, traumatic injury.
And that facet, you can see on this image here, is undergoing some recovery on its own, but it was still painful. And Dr. Hrynkiw fixed that segment and realigned that segment,
Yes.
which is subtly out of alignment. What I would like to emphasize is most people, as they age, will wear out at C5, 6 and C6, 7. So 2, 3, 3, 4, 4, 5, 5, 6, and 6, 7. Those segments are probably the segments that you most often operate on. I would venture a guess.
Yes, in the neck, 5, 6, and 6, 7 are the most common, and in the lower back, L4, 5 and L5S1 are the most common.
Yeah, I used to say that L5S1 belonged to my son, and C5, 6 and C6, 7 belonged to my daughter. Like, that's what I would use to send them through school.
Okay.
Because they're that common.
I like to tell patients with degenerative disc disease, it's like you buy a car, it's got great tire tread. You drive it 20,000 miles, your tire thread's worn down.
Yeah.
And that happens.
And what I tell patients is sometimes I'm just a glorified hairdresser. I'm not fixing the underlying problem. I'm putting medicine at C5, 6 or C6, 7 and just putting some hair color in there to cover up the gray hair. And it's so a lot of times it's a temporary fix. Whereas you may operate on 5, 6, and 6, 7, but then when you do that, that makes C4, 5 susceptible to break down.
20% of the time. There are different ways to fix a disc, and traditionally what we've been doing is removing the disc, replacing it with bone, and then putting some plate or screw or something to hold it together. We call that a fusion. But the spine was actually made for motion, and if you fuse a segment of the spine, about 20% of patients will develop adjacent level disease. That is, the disc above or the disc below will start having that deterioration.
And then the same problem occurs.
Higher up or lower down, 20% of the time. Continuing on the spine.
So you put a new image up? Or yes,
this is
okay.
a different image. Now
Okay.
this is a patient who is a young person who presents with, again, this is normal up here. This is a normal healthy disc, normal healthy disc, normal healthy disc. And here's L4 and L5. You see this disc is sticking out like a thumb coming into this water sac, which we call the cauda. And looking over here, this whole thing is the disc, and this little area over here is the compressed nerve roots. Now this patient had severe bilateral or both leg pain, but she was developing some bladder incontinence.
So she was leaking urine on herself.
She wasn't aware that she was doing that. In addition, and also, she could not raise up her foot. We call that a foot drop. So we did this as an emergency, and that's one of the indications for emergency surgery is loss of control of bowel or bladder or a foot drop, which we call a neurological deficit. This is rare, but can occur, and we'll probably see one every 3 months in a fairly reasonably busy practice. So not all disc ruptures need surgery, but some need it as an emergency. We did not try a block. We did not try physical therapy. We did not do anything but take her to the operating room, and she had surgery within 24 hours of my seeing her because of the symptoms. Now, if this lady had no bowel or bladder dysfunction, had no foot drops, she'd have gone through the physical therapy, conserved modalities, anti-inflammatory agents, muscle relaxants, pain medicine, blocks first. But even though the scans are fairly similar, the clinical presentation is markedly different.
So there's another question. Let's see. What are current medical and surgical treatments for glioblastomas?
Glioblastoma.
So we're moving out of the spine, we're back into the brain, folks. Just so you know, glioblastoma is a brain tumor.
Okay, so someone has read my mind, because on this screen over here, and this is the cerebellum part of the brain. Here's the eyes, here's the nose, but this is the back part of the brain that controls coordination. This is a young female who not that long ago presented with severe headaches. And this is a atypical glioblastoma, which is a malignant cancer of the brain. Usually we see it up here in the hemispheres. And glioblastoma's gotten a lot of publicity lately because, for example, Senator Kennedy, Senator McCain have been diagnosed and have died from glioblastomas.
Don't become a senator, Hunter. You hear me?
Statistically, the national average of survival after diagnosis used to be 48 weeks. It's gotten a little bit better, but the current treatment modalities is aggressive surgical resection if possible, followed by radiation and chemotherapy. Now, I've had
and you're
patients,
saying once it's diagnosed, the average lifespan is less than a year.
It used to be that, yes. Now, I've had one lady that I did surgeries on several times, and she was able to live about 10 years and had 2 children and had a normal life for 10 to 12 years. So there are exceptions. Now they're doing genetic typing, and some glioblastomas act a little more aggressive than others, but radiation and chemotherapy is the standard of care. There's new things coming out, immunotherapy. Duke University is doing that. Other universities are. There's a trial down at UAB. There's a machine called a Neptune that using magnetic waves people are wearing. But basically, surgical resection for the glioblastoma, remove as much of it as humanly possible, followed by aggressive radiation and chemotherapy.
Are there any more questions, Hunter? Any more cases you have queued up for us then?
Let's see. This is another thing we see. We talked about cervical pathology from trauma, but this is not trauma. Here's the spine, white as spinal fluid, and this is C2, C3, C4. C5, C6 has a fusion, and behind the body of C6 you see this large lump of tissue. And if we're a loaf of bread and we're slicing it to put peanut butter and jelly, right over here you see this soft, round mass.
It's huge.
This is a huge ruptured disc.
Huge.
This patient had a history of fusion at 5'6", now developed severe neck and triceps pain bilaterally. And you can see this ribbon over here is called the spinal cord, and over here you can see how it's displaced.
Now,
It's
have you
humped over.
operated on this?
Yeah. We did this patient as an outpatient. He was admitted, taken to surgery. We removed this, put bone here in its place. I personally use the bone bank. There are other alternatives, including mechanical artificial discs. And we put a plate and screw here to hold everything together. We call that an anterior cervical fusion. And this patient did extremely well, went home as the same day, and basically has been discharged from care doing well without complaints.
Do you think some of that tissue there is blood? Because if you stuff that all back into place,
Mm-hmm.
it would be like an overstuffed cookie. You know what I'm saying?
No, I don't think it was blood, because I operated on him. I didn't see any blood. I mean, it was all this crab meat that we pulled out, which we call a disc
I'm just
herniation.
curious because it looks so large, you know,
Very
relative
impressive.
to his neck. So here's a question. Ask the difference between a neurosurgeon and an orthopedic spine surgeon.
That's a good question. Historically, a neurosurgeon was the nerve's best friend, and an orthopedic surgeon was the bone's best friend. Now, when we're talking about spine, the spine is complete. And now with the fellowship program, everyone getting cross-trained, there are very good neurosurgeons who do spine, and there are very good orthopedics who do spine, and it's really gotten to be kind of an almost Those who specialize in spine can do spine. Doesn't matter if you're a neurosurgeon or an orthopedic surgeon.
In fact,
However,
for years you worked with an orthopedic surgeon,
I
as I
did.
recall.
However, most orthopedic spine surgeons will not do work inside the dura or actually on the spinal cord itself. They'll do the disc work around, but once it got in the dura, like spinal tumors which occur, they would not do it. But that's historical, and there are excellent orthopedic spine surgeons, but they've gone through specialty training in spine.
So one more question. Are there any overt advantages of bone grafting versus artificial disc use?
Artificial disc use have been improved in the United States for several years now. In the lumbar spine, most insurers will not pay for it, so it's not being used very much at all. In the cervical spine, in the last 10 years, it has been approved, and there are some advantages and some disadvantages. The advantages of an anterior cervical fusion, putting bone in its place, is we have a track these 1940s. Clower did his first anterior cervical fusion in 1940 or 42. So we know the results. They're out there. They're very good. In the United States, the artificial disc has been only out for about 10 years, so we don't have really long-term follow-up. A fusion will eliminate some motion, about 8 degrees, while artificial disc does not eliminate motion. But most patients that we see are not the young, healthy candidates for an artificial disc. A lot of our patients have degenerative arthritis, spurs, calcium deposits. They don't have the mobility, so putting an artificial disc in them isn't really that worthwhile.
Are artificial discs covered by regular insurance in Alabama?
Most of them are currently. It's
Okay.
changed over the last few years. So we do put an artificial disc in. I had an Air Force pilot from Iran war, come in, and he specifically wanted it because they wouldn't let him fly his fighter jet if he had a fusion in his neck. So there's some indications for it. It's a simple procedure. It's the same exposure, but not everyone's a candidate for it because you have to have a young, healthy, mobile neck. And a lot of our patients are in their 50s and 60s, and they just don't have that. But it's a definitely good question, and we still do them.
Okay. So somebody out there, you said, read your mind. That was pretty impressive to read a neurosurgeon's mind.
Well, we're not there smart.
Can you read people's minds as a
No.
neurosurgeon?
No, not yet. Working on that.
All right. Wow, there's another huge disc then.
Yeah, this is a huge disc, and I brought this one out for. This lady came in with back and leg pain, denied any bowel or bladder symptoms. You can see this huge thing. Denied saddle anesthesia, no urinary incontinence.
Presented with just back pain?
Back and right leg pain.
Okay.
She says it's fairly severe. And I immediately wanted to operate on this because this just really impressed me.
Uh-huh.
And I said, gosh, let's do surgery. I'll do you like this week. And I think we're going on 3 months, and she's changing jobs and this and that, and she's actually living comfortably with this. So sometimes you can see this monster of a disc that you would think would be causing all the symptoms in the world, and this lady doesn't want surgery because she's not doing bad enough, she tells me.
That's great.
Which is great for her, but it's just amazing somehow sometimes a little disc can cause such significant pathology, and a huge disc can cause so little pathology. So the size sometimes really doesn't matter.
Zen, how do people get a hold of you? Do you know your own office number?
Do I know my own office number? Yes, it's 205. Oh, here's something I wanted to show
All right.
you. We do also congenital.
Okay, so this is in the spinal cord or something.
Yeah, this is kind of an interesting. This is the spinal cord, and over here you see this big white mass. That's a cyst in the spinal cord, which we call a Chiari Malformation. It's a syrinx from a Chiari Malformation. This is the actual syrinx, which is, and here, this is the cerebellum. Here is C1, and you see part of the cerebellum is gone down.
It's dropped down out of the brain.
So this is a Chiari Malformation with a syrinx. So not only do we do degenerative and trauma and neoplasms and strokes and blood clots, we also do congenital. This person's in their 40s.
And how did they present?
Severe neck pain, severe headaches, numbness and burning in the hands.
Okay,
So this patient needs surgery.
absolutely. Any questions?
And here is another case.
Oh, good. We're good. We'll keep going.
Well, I just wanted to show this one because
All
this
right.
is, I'm going to block out names here. This lady presented with severe headaches. Now this is what we call a sagittal view. I did her last week. This is her scalp. Here's her eyeball. Here's front. Here's back. And if you kind of follow her scalp, you can see this lump.
It's coming out of her brain.
And then if you look here, this is the brain. And here is the covering of the brain. We call it the dura. And here inside the brain is a brain tumor. That's a brain tumor. However, not only is it indenting or invaginating into the brain, it's actually, this white is eaten through the bone. The bone is black here. It's eaten through the bone, and this over here is in the scalp. So when I touched her head, I can feel this mound. It was tender to the touch, and she's had that and ignored that for about a year, she said. And she presented, and she had subtle right-sided weakness and severe headaches. So I did this patient last week. I removed the whole skull bone here, removed the lesion up here, removed it down here.
Don't show names.
I can't show names, so we're not going to show this.
Is this an intraoperative CT?
No, this is her post-operative CT. And the tumor's all gone, as you can see over here. And I reconstructed her skull with a wire mesh. And you see there's no tumor. The black is some air from a surgical bed. And she's actually been discharged already neurologically, doing extremely
What
good.
was the tumor?
The pathologist felt that it was a meningioma, which is a benign tumor of the coverings of the brain.
So benign meaning it was
Non-cancerous.
non-cancerous.
But even non-cancerous tumors can grow.
There was a question on there about robots. Is that right?
Yes, are spine robots all that they are cracked up to be?
I have an
Not
answer.
from me.
Spine technology and neurosurgery is really exciting because of all the new technology. When I was a resident, we didn't even have a CAT scanner. Now we have CAT scans. We have MRI scans. We have intraoperative CAT scans, and now we have robots. Grandview, where I operate, has had a Medtronic Mazor robot, and now we have the newest, fanciest version of it, best in town, best in the state, actually. And I've used it quite a bit lately, and is it that much better? Not really. It does, if you have a very, very tiny pedicles, it can, technically, it's reproducible, should cut down the amount of errors. Is it a life changer, or is it really a major innovation? At this point in time, I think it's a useful tool, but I can do the same case without a robot just as well as I can with a robot, although I'm using the robot so that I'm more experienced, and when I need to use it, I'll be more proficient at it. But we've done a fair number, and the results are good, but I can't say that it's actually better than our old-fashioned techniques.
So maybe it's a little bit of a marketing tool to say, hey, we're doing robotic surgery.
Used for robotic surgery in the future. Right now, the way it's used in spine, the robot actually doesn't do the surgery. The robot puts you where you want to be to put your screws in, and that's all it can do at this point in time in spine. Although there's a lot of interesting things in the development phases that are not available yet.
All right, can we give out a number now, Hunter? Let's do it.
205-971-3566, Grandview Medical Center, 205-971-3566.
Awesome. Thanks, Zen. I appreciate it.
All right,
That
thank
was
you.
great. Appreciate it.